Hello, this is Morton Kern, interventional cardiologist in Long Beach, talking to you on behalf of our CCI Conversation in Cardiology of Interesting Cases. And we have a wonderful case to discuss today, authored by Dr. Gabriele Gasparini. And also we have in attendance Dr. Antonio Mangieri, which name I goofed again, but and Steve Bailey and Mirvat Al-Sanag with us. And the case involves, and we'll hear about it, the case involves this use of a cutting balloon called the cuttering or cutting dottering technique for treating a flow-limiting intramural coronary hematoma. And I think this is fascinating. The imagery is good. The technique is good. It stimulates us. So without much delay, Dr. Gasparini and Dr. Mangieri, would you introduce yourselves briefly, what you do, where you are, and then I'll ask you to tell us about the case.
Okay, thanks, Morton, for the introduction. My name is Gabriele Gasparini. I am an interventional cardiologist working at Humanitas Research Hospital in Milan, Italy, where I am the director of the CTO and complex PCI program.
Wonderful.
Hi, everybody. Thank you for the kind invitation. My name is Antonio Mangieri. I work as an interventional cardiologist together with Gabriele Gasparini at Humanitas Hospital in Milan.
Steve Bailey, I'm here in San Antonio and enjoying life and enjoying the journal. Thank you, Morton.
Wonderful. And Mirvat, can you introduce yourself too, please?
Well, I'm a digital editor for CCI Journal, and it's just fascinating to see all these cases and these discussions.
Wonderful. So I'm going to help us through this case, but Dr. Gasparini is going to tell us what he found. So let's go to that first slide.
Yeah, so we're going to discuss about this technique that we recently published, that it's called cuttering technique. Cuttering is a combination between cuttering and dottering technique. So it means that we have to adopt two different techniques, because usually when you have to deal with the coronary artery dissection, the main problem is represented by the intramural hematoma, because they often create an impairment of the distal flow. So the point is, when you have to deal with flow-limiting hematoma, the only chance that you can have is to create some fenestration using the traditional inflation of a cutting balloon. This has been already described into the literature. Okay. This is probably the most interesting part, because in this case, you can appreciate really a huge hematoma into the distal right coronary artery that was created during a CTO procedure because of inadvertent antegrade injection after a retrograde dissection and re-entry strategy after a reverse guard. So in this case, you can appreciate a huge hematoma into the distal right with this contrast staining. We try to inflate just in the panel B a standard cutting balloon. You can appreciate the blades that are acting against the hematoma without any effect in terms of drainage of the hematoma. So we started to apply some sliding movement in terms of back and forth movement, leaving the balloon inflated, the cutting balloon inflated. In this, adopting this sliding motion of the cutting balloon, we were able to achieve a complete drainage of the hematoma, as you can appreciate in the panel C3, and also in D, achieving an excellent angiographic final result after stenting. So this is the first case that we did, where we applied this technique because it's based on some physics principle. The sliding.
Yes, excellent. Can you show us that diagram that you provided to the case?
Yes.
And also I had a couple other questions. Yes, so this is
we have, if you go into the last slide, you can also have the video that can also explain you better what we did. This is the standard cutting balloon inflation without any drainage of the hematoma. Then, leaving the balloon inflated, we started to adopt this cuttering, and at the end, we were able to drainate to obtain a complete evacuation of the hematoma, as you can appreciate here, thanks to the completely disappearance of the contrast staining. So the rationale of this technique, we have several other interesting picture, also with some information coming from images. We have also IVUS and OCT as well. So the rationale of this technique is that when you apply sliding movement to the inflated cutting balloon, the benefit that you can reach in terms of creating some cut or some fenestration is higher compared to a traditional cutting balloon inflation because of two main mechanisms. The first one is concentrated force, and the second is progressive cutting. The concentrated force is mainly due because when you apply just a vertical force on the blade, the pressure that you can exert, it's really high in terms of creating some cut or cracks. This is the mechanism why we are using cutting to crack calcium and when we generally go up to high atmosphere. But in this case, we don't have to cut a hard tissue. It's just a soft tissue. So we need to concentrate the force on the edge of the blade. So with the sliding motion, we move the force on the edge of the blade. And in this case, we are able to achieve more easy a cut into the tissue that we have to break. And also in this case, we have also progressive cutting.
Okay, so let me just ask a small question. Dr. Mangieri, what atmosphere should we think about when you're using that technique? And are you not concerned you might lacerate through and produce a perforation?
Yeah, I think this is one of the key questions, yes, to perform our technique. So our suggestion and the best benefits that we have observed in our cases is to inflate the balloon at very gentle atmospheres, so nominal pressures, 6-9 atmospheres, no more. While, for example, in the COPS trial that we have published on CCI a couple of years ago, we suggest to inflate the cutting balloon at very high pressures, but downsized compared to the media to media diameter. In this case, I think the 1-to-1 size compared to the vessel diameter is recommended, and is one of the idea of Gabriele doing this technique. And the inflation should be no more than the pressures that I previously suggested. If you have some troubles in advancing and pulling back the balloons while you're doing the cutting dottering technique, you can also go to lower atmospheres, 2-4 atmospheres, just to make sure that the blades take contacts with between the true and the false lumen, just in order to create some cuts in between.
Yeah, let me add just an important point that this technique is not recommended when your wire is having a subintimal tracking. For example, during ADR or the STAR technique, when you are with your guide wires into the subintimal space, it could be better not to adopt this technique. This technique should be applied when your wire is intraluminal. You maybe have a huge hematoma because previous angioplasty, because of the previous subintimal tracking, but it could be better to avoid this technique inside the subintimal space because you can carry the risk of creating perforation.
Sure. I recall in days past, long past, that we attacked these intimal hematomas with a number of odd techniques of attempting wire perforation or an external wire focus force balloon or some other kind of things. We didn't use cutting balloons prior to this time for trying to cut tissue inside the artery. So I think this is really a observation of importance for this management. The key was to be wire intraluminal and then cutting inside, because the adventitia, as I understand it, is fairly strong. If you perforate, it can be perforated, but it will stand some force. So yes,
this is a situation that can occur during a standard PCI. It was in this case an inadvertent rupture of the balloon. So it's something similar to the grenadoplasty, but it was not intentional. So we inflated the balloon into the very tight and calcified plaque, a small balloon, and we have an inadvertent rupture of the balloon. And of course, this rupture create a barotrauma with subsequent dissection. You can appreciate the contrast going to subintimal space toward the PDA and the posterolateral branch as well. And we have a picture and the video of the cutting in this technique. We advanced the balloon. We have another video, the next one. We inflated the balloon. You can appreciate how big was the hematoma here. We have another video. This one. Look, the balloon, this is a cutting balloon. We inflated the balloon at 6 atmosphere, and then we advanced the balloon, and we adopted the cutting balloon into the PDA, and then also into the posterolateral branch. We did exactly the same. We have the next video. Yes, you can appreciate how easily was advanced the balloon. It was gently inflated, and we created this evacuation of the hematoma. And we have also the imaging, the IVUS findings before and after this technique. So maybe you can show also the picture with the IVUS. This is this is the final result. So with a complete restoration of TIMI3 flow in all the distal vessel, the PDA, then the 2 posterolateral branches as well. But so we have this one. So it's really fascinating. I'm really fascinated by this imaging because on the panel B, you can appreciate the IVUS probe into the true lumen, and the subintimal and the asterisk sign the hematoma. Usually, IVUS show the hematoma has a bright gray. In terms of IVUS gray scale, the normal blood flow is something like dark gray blood speckle, and the stagnant blood flow is something similar to bright gray blood speckle. And on the upper part of the panel, you can appreciate how bright is this gray in terms of stagnant blood into the hematoma. And in the panel F, after cathetering, you can appreciate both in terms of fenestration. The white arrow show you the fenestration created by the cathetering technique, and also a complete change in terms of IVUS grayscale of the blood inside the false lumen. Now we have dark gray blood speckle. It means that we have no more stagnant blood flow into the subintimal space. So we still have 2 different lumen, but with a complete drainage of the hematoma. In this case, you don't carry any risk of creating some compression, external compression of the true lumen, because the hematoma is completely evacuated into the distal true lumen.
So let me just ask, is this image in panel F, it corresponds to the angiogram on panel E, but it looks to me that the true lumen is still small. Is that correct?
Yeah, is it correct? So the problem is not necessarily related how big is the true lumen, because we have learned a lot from the experience with the DCB and also with CTO that dissection will spontaneously heal over time. So we are not worried about the persistence of the dissection, but the main point is the distal TIMI3 flow. So the main predictor of patency after this procedure, even if you leave a dissection untreated or unstented, is to have a good distal TIMI3 flow. Once you are able to create fenestration to evacuate the hematoma into the distal true lumen, you can leave the vessel without any stent, and you will definitely find the dissection completely healed after 6 or 8 weeks. And we have another interesting follow-up in the next picture. This was a spontaneous coronary artery dissection in a young woman, and we applied the cathetering technique, and you can appreciate in the panel E and F fenestration between the true lumen and false lumen, with this also change in the IVUS grayscale into the blood speckle of the hematoma. And then the OCT was performed during the angiographic follow-up after 6 months. This is really fascinating because, in our opinion, once you created several fenestration and applying this technique, you can have more fenestration compared to a standard cat in balloon inflation with a standard single cat in balloon inflation. Once you have this high number of fenestration, the lumen, the final lumen, become the same. No difference between true and false lumen, because in this case, we have several connections along the vessel, along the dissection plane between the false and true lumen. So in this case, this section will not heal spontaneously over time because there is no reason, because the blood comes between the false and true lumen, reaching the distal part of the vessel, reaching the distal collateral, the distal side branch, without the need. You can appreciate the difference between panel H and panel I, because
Yes, so
we are talking about the same, but at the different level of the artery. But at the end, we have created a good distal TIMI flow.
this is fascinating. So, a couple of questions. So, in panel H, that fenestrated tissue, that is visualized after a few months. What time did you see it? And then for Dr. Mangieri, should we be thinking about this for all of our spontaneous hematomas that occur in our acute young patient coronary syndromes who have spontaneous dissections? Is this something we should be thinking about?
I think it should be, Gabriele, you want to comment about the first question?
Yeah. I mean, it was a follow-up that was scheduled more or less about after 6 months.
Fantastic. So that piece of tissue can stay there without causing any problem at all. Blood flow is good. There's no adherence. There's no obstruction, no thrombosis.
Exactly.
That's what it looks like. And then, so this technique, can I apply it to anybody with a spontaneous coronary artery dissection?
I think we have to remember, Gabriele, I don't know what you think about that, but it's always like a last bailout option when we have flow limiting dissection. Of course, when we have SCAD, one of the best thing to do is not to go straight forward for the intervention, but if you have already good distal TIMI flow, you can live like that and just manage medically. But if in case you have a challenging scenario, I think this technique can be a game changer in our clinical practice, because the idea to balloon sometimes is not a good idea, because in general, what we do going high pressure with standard balloon is just to squeeze the hematoma. Sometimes we can create some connection, but the risk is that we propagate the dissection distally, and it becomes more challenging to create a good connection between the true and the false lumen. So I think our let's say technique is a good option, because we don't go high pressure and we try to create fenestration in a gentle way.
Yeah, that's the point.
Yeah, go ahead. I'm sorry.
Sorry. That's the point, because the difference between calcium and dissection or hematoma is exactly what we pointed out. And in calcium, you need pressure. But in this case, we don't have to crack hard tissue. We don't need pressure, because with pressure, we can end up with a squeezing phenomenon of the hematoma, propagating and facilitating the propagation of the hematoma distally, with the worsening of the distal TIMI flow. So in this case, we don't look for pressure, but we just look for cutting effect. And the sliding motion, we observed in our experience that the sliding motion really improved the chance to create cut.
Okay, last question. I'm sorry, Steve. Go on.
No, I'm struck by the images that you have and wonder how important intravascular imaging is in the two of your decisions. One is size of balloon. I can see where that might influence size of balloon. And two, can you use, or do you use imaging to tell you how far you want to advance and withdraw your catheter? You seemed pretty aggressive in that one image about where you passed your balloon. I'd be curious about whether you image these regularly to make any decisions and how that influences your approach.
Yeah, you're totally right, because imaging, first of all, give you the information if you are completely intraluminal. So this is a safety issue because we already discussed about this technique should be applied when the wire is intraluminal and you want to create some decompression coming from the subintimal space. Then you are right. The first video that we have shown you was the first application of this technique where we didn't use imaging. Then, collecting more experience and more data, we started to use imaging. And in this case, imaging is really helpful because it can also show you how long is the dissection plane, not only in terms of the axial view, but also in terms of the longitudinal view. So this will help you to understand how long you should advance, how distal you should advance your inflated cutting balloon. Regarding the diameter, we started with a 1-to-1 sizing of the cutting balloon. Then we modify over time. And now we tend to just a little bit undersize the balloon, 0.5, because we don't need to, because the external compression of the hematoma push the material, the endothelium that we want to cut directly against the blade. So we don't need to have a 1-to-1 balloon because the lumen is still compressed. So we have the contact between the blade and the endothelium.
Good. I'm going to have to tell us that our time has run up, and this has been a fantastic discussion. Dr. Gasparini and Dr. Mangieri, I think this is a very excellent case. It stimulates us also to think how we may apply it in other circumstances where an intramural hematoma is causing trouble and gives us an option. So with that, I'm going to say thank you both for presenting to us. Dr. Bailey, Dr. Alasang, thank you again. It was really a pleasure to be here. So we'll say goodbye for now.
Thanks for having us. Thank you very much.
Thank you for the opportunity. Thank you so much.
Thank you both.